This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I am TG LaFredo, and today I'm coming to you from the emergency department at Kingman Regional Medical Center. My guest is Dr. Clarke Snodgrass. He is an ED doc here. Dr. Snodgrass, welcome.
Yeah, thanks for having me.
I corrected myself. I said today. I said this morning. I have no idea what time it is. I think it's after 1 a.m. Go ahead, help me out. It's 1:11.
1:11 a.m.
All right. 1:11 a.m. I love this because I am a nocturnal weirdo, and I get the feeling that you have to be. That's like a prerequisite for your job here, right?
Yeah, that or you're forced into it. You don't really have a choice.
Which is it for you?
I'm kind of more the nocturnal weirdo, but when I'm not working, then it just is pretty terrible. I'm trying to get,
right.
I got a 2-year-old at home, so it makes it a little difficult, but we figure out a way.
You just nap when you can.
Exactly.
Do you ever just catch yourself, like you wake up at a stoplight?
No.
Okay.
Thank God, no.
Don't confess to that if you did. How long? So this week, Doc, we're talking about the ED, what you do here, also the fact that KRMC is a teaching hospital. This is a fascinating place, and I'm really excited to be here in the middle of the night. Give us a little insight. How long have you been here at KRMC?
Yeah, so I actually came out here in 2019. So I completed 3 years of residency training here in emergency medicine. And about halfway through my third year here, I was offered a position as core faculty within the residency program. And really enjoy teaching. As residents, we get a lot of medical students that are coming through here and rotating. And I've always really liked that aspect of the job, is getting to kind of teach while you work. So it was a really good thing to be able to get that job offer and to stay. My wife and I are here with our almost 2-year-old, Stevie, and we really like our place here. We really like the desert. She's actually from kind of the high desert, Ely, Nevada. I'm actually from St. Louis, lived in Denver for medical school after that. But I've really grown to like the desert and a lot of the activities around here.
Yeah.
Now I'm going on year 2 of attending.
When you were looking for those who are unfamiliar, KRMC has residency programs for family medicine, for ED docs, and also for the pharmacy. When you finished med school, you had your choice of wherever you wanted to go. And why did you choose KRMC? What was the draw for you?
Yeah, so I had the opportunity to rotate out here as a third-year medical student. Just kind of on a whim, I was really interested in emergency medicine. For our medical school, they just started offering this rotation. So my buddy and I kind of piggybacked it on a ski trip. So it worked out well that way. And I really enjoyed it out here. I liked the training. I saw a lot of the residents were getting a lot of autonomy. They were seeing a lot of patients, a lot of advanced pathology. And then I come to really like working in the rural setting. So it was just a really good fit for me. Through my 4th year, I rotated at a couple other big academic centers. And it was, I would call it a little more hands-on, and I'm not saying that in a way that we're not hands-on here as faculty, but you're getting to do a lot more earlier in your training, just because if you go to a bigger center, there's a lot more residents, there's a lot more senior residents, a lot more specialists and fellows. So, when you have anything that comes in that's, say, related to orthopedics or to ENT, you'll have an orthopedic resident down in the ER doing the procedure. Whereas here, we're unopposed, so we get to do everything.
I know that when I've spoken with providers in the past and docs, and they say, we talk about the realities of working in a medically underserved area. It seems like one of the benefits is you learn to be good at a whole lot of things because, as you say, there aren't specialists here ready to go, or some specialties, yes, but some not. And so you've got to have this whole other skill set that you develop.
Yeah, definitely. I mean, you definitely have to be a lot more adept at a lot of different procedures here. And, as time goes on, you got to be a lot more comfortable with your role as also providing primary care to patients that aren't going to routinely get into primary care. There's patients you'll see routinely that have been here 20, 30, 40 times, and you'll look through every discharge instructions and there's referrals to primary care physicians, and for one reason or another, they just haven't gotten in to see one. So, we've kind of taken it upon ourselves to try to fill in the gaps a little more, I should say, on, some of the primary care treatments as far as like high blood pressure and diabetes.
We said that you are an alumnus of the. Yeah, no, I'm off the script. If
No,
you're
it's all
looking
good.
at my questions, we said that you are an alumnus of the residency program here at KRMC, and part of the goal for these programs is to find and identify good docs who might then decide to stay on and become full-time employees, which is just what you did. What went into that decision for you?
One of the biggest things was being able to stay and teach. There's pretty high burnout rates in emergency medicine. I think just for what the job entails on a day-to-day basis, if you're only doing clinical work every day, it can be very exhausting. And, with that comes a lot of burnout. So being able to be around residents and being around that like young, fresh energy, people that are excited every day, getting to teach, definitely brings like a different dynamic in to the job. And then outside of, ER, we do didactics, and I'm the director of simulation within the residency program. So getting to put on simulation events for the residents is fun. And then just really getting to see the residents grow is probably the best part about it. Seeing a resident come in as an intern and, just deer in the headlights on day one till their second year, they're running a code independently.
Yeah.
With me just standing in the corner.
Okay, so there's so much to talk about there. Tell me a little bit about the kind of doc who's drawn to emergency medicine. What is that personality type?
I mean, the classic would just be the adrenaline junkie, So a lot of people are very into the outdoors. Emergency medicine has wilderness medicine paths. You can go do a fellowship in wilderness medicine.
Of course.
Dive medicine, a lot of outdoorsy stuff. But yeah, I would say definitely people that are a little ADHD. They got to be moving all the time. They would get really bored if they were seeing the same thing over and over again. And they do well when they're pulled in a lot of different directions.
Mm-hmm. Have you had doctors come in thinking this is what they wanted to do, and then after getting a taste of it, they've said, this isn't for me?
I don't think too many residents have been down that path. By that time, through medical school, they've done enough rotations where they've really solidified this is what they want to do. Mm-hmm. But we definitely get medical students that rotate through here, and by the end of it, they're like, that was great and all, but definitely not for me.
Enough of that.
Yeah.
I was looking at your credentials, and you mentioned director of simulation. Give me an example, if you would, what that job is and maybe what kind of simulations you put together.
Yeah, so we do simulations that are from the very basic as far as simulating a procedure. And we have different lifelike mannequins that essentially can give you feedback. And so we'll do particular days that concentrate on a vascular procedure or an airway procedure. And then on the grand scale, once a year, we put on a mass-casualty incident here at the hospital. And so, for instance, last year we had a lot of the first responder agencies in town that participated in the event. Stevie Merrill, our associate PD, is also one of the physicians here in the ER, was able to get us an old plane from the airport down there. And so we essentially did a mock-up airplane crash that had drugs on board, snakes on a plane.
Yeah, wow.
And so we had, I want to say, probably 30 to 40 patients that came in. So some of them were brought in by ambulance, and these are all obviously actors, right? We had a bunch brought in on a school bus. We had a couple arrive via helicopter. And we essentially run this MCI event, is what we call it. And to just kind of get training for that. And we get as many people involved as we can that aren't working at the time. And we normally just kind of section off a part of the ER to kind of get us prepared if we were to run into something like that here in the community.
And while you're running that, the hospital still has to do its regular daily business.
Yeah. It's kind of confusing. It's almost hard to tell who's an actor and who's a patient,
Yeah.
So it's a little chaotic on those days.
For the actual patients, there's a lot of explaining going on, I guess.
Yeah,
right?
I mean, as far as I'm aware, yes.
Well, you said that you're interested in didactics and trying to create a good program for the residents who come here. What are some key experiences you want them to have that you can say, now that we're turning you loose, you're ready for this?
Well, there's no better experience than the real thing, right? So what we really try to facilitate here is given as much autonomy as the resident is ready for. And that's really the most important thing that can prepare them for practice once they get out. And another important thing that we're able to do here in Arizona is we're able to moonlight through our halfway through our second year, so you can actually go out and start working at different ERs independently. And that's really helpful as well. There's probably nothing more helpful than that, getting out there on your own and not having that safety net. We always tell residents, like, tell me when you're working, and if I'm on any of those nights, call me if you have any questions.
Okay.
But it's rare that you get a call. They're normally ready to go by the time they get out there.
Yeah. I wonder about some of the kind of medical legal aspects of the job. It seems to me it's high risk and high reward, but there's a lot to lose, and there will be a certain amount of patients who will show up and they'll be in grave circumstances and they won't survive.
Mm-hmm.
Does the nature of this job leave you at a higher risk in terms of, malpractice claims?
Yeah, I'm not quite sure what the landscape looks like as far as across specialties. But I'll tell you, there's definitely a lot of issues within emergency medicine, not just here, but across the country and in hospitals nationwide, that definitely makes you feel a little more vulnerable. Mm-hmm. And some of those things are long boarding times in the ER, which we had a lot of issues with during COVID, obviously, and you saw it everywhere.
You and everybody else.
Yeah, and I think you've seen a lot of lingering problems with that sense, as far as hospitals having a difficult time with employee retention, especially on the nursing side of things.
Yeah.
So sometimes we might have beds available, but we don't have staffing that's able to fulfill those needs. And I will say our hospital has done a very good job, and that's not something that I have seen very frequently lately. You still have it day to day, and that's kind of the nature of the beast, mm-hmm. In any hospital. Sometimes just for unexplained reasons, you get big waves of patients, and you might also have a nurse or two call out that day, and that can dramatically change, kind of the flow of patient care. Mm-hmm. So the long boarding times in the ER, it would be one issue. And specifically what I mean by that is someone that we have already evaluated, we have all their testing back, and we know they need to be admitted to the hospital, might still have to stay down in the ER for a period of time.
Yeah. Well, it's not that busy tonight.
No, we're...
Oh, no, I just committed the deadly sin.
Yeah.
Oh, no. Yeah. So anything that goes wrong is going to be my fault.
Yeah, I'll let the nurses know.
I said the Q word. I was talking with your colleague, Dr. Adam Dawson, and he said, I have no superstitions. I'll work on full moons. I'll work on Friday the 13th. You can say it's a quiet night. I don't care. Uh-huh. I'm not afraid of anything. Is the superstition, is that prevalent around here?
Oh, yeah.
Yeah.
I'm kind of like with him. I don't really believe in any of that.
Uh-huh.
I a lot of times will, say those kind of things, just kind of irk the nurses. But yeah, I mean, if you say that out there in the open, yeah, you'll have a lot of ugly stares coming your way.
If you're just joining us, this is Focus on Your Health. I'm TG LaFredo, and this week I'm coming to you from KRMC's Emergency Department. My guest is Dr. Clarke Snodgrass. It is the middle of the night, and we're recording this show, and I don't know about you, but I think that's fantastic. I always wanted to have like a middle of the night radio program.
Yeah, no, this is great. We got super lucky right now that the night ended up like it was. It was super busy when I first got here.
Yeah, same here.
So it was, it's kind of surprised it's slowed down enough that I've had time to come back here. And
it beats having to work, doesn't it?
It does, yeah. This is actually pretty nice.
Quick check of the phone, everything's okay?
Yep.
You see people in all kinds of situations, maybe with trauma, maybe after a vehicle wreck or something like that. For basically whatever comes through the door, is there going to be a procedure? Do you have like a list of bullet points that you'll say, okay, we've got this patient, do this, do this, do this, and then you are covered? Or is there a fair amount of jazz improv that's going on? Help me to understand it.
Yeah, so there's certain criteria you got to kind of have to be able to be discharged. But like everything in life, nothing's black and white. There's a lot of gray zone. There's a lot of taking into account the particular patient and taking into account what's important to them, what kind of care they want to receive, and what their risk tolerance is as far as, if we're recommending for admission or transfer, and they're adamantly against that for XYZ reason. Our goal is to really make patients duly informed on what's going on with them and to give them all the information so they can make a decision for themselves with our recommendation in mind.
Yeah.
A lot of times it's really just working with the patient and seeing what kind of best fits their goal of care.
If I were an emergency department resident just arriving for my first shift, what kind of advice would you offer me? Or would you just say, jump out there, get to work?
Yeah, I mean, I think you just kind of have to jump right into it. But, it's when you first get here, I think it's important to spend time with patients, be thorough. If you're doing more than what you need to, that's fine. Yeah. Over time, you'll learn how to kind of back off and not do as much testing and to do more discussion with the patient and kind of fall back on a little more of your experience as far as what needs to be done. But yeah, I think it's the most important thing is to ask a lot of questions, to learn from everyone in the department, nurses, techs, everyone has like so much valuable information to provide, and to not think you're above learning from anyone would be the big thing, and to listen to patients. So you should be spending majority of your time in the patient rooms doing reassessments. Nowadays and age, it makes it pretty difficult because healthcare has become so documentation heavy. Electronic medical records are great for a lot of reasons, and they also have a lot of downfalls. And I think, this oldest generation of docs that are still practicing now, if they had one complaint, I would say most of them would think it's the documentation. There's some crazy studies out there, and I can't quote them exactly, but I think some of them show somewhere between like 60 and 80% of your time of patient, is spent in front of a computer.
Does AI stand to change all that?
I think it's going to have a huge role in the future in a lot of ways.
Just today, or yesterday, since it's the middle of the night, just yesterday, I was reading a national news article about the use of AI in writing police reports. Mm-hmm. And basically, this system was integrated with an officer's body camera. And after this interaction, the report was finished in 8 seconds. Mm-hmm. And the officer reviewed it and he said, it's all correct. In fact, it's better than I could have written it on my own. But, we're talking about a lack of staffing, and we're talking about some of the challenges in that regard. There's the potential here, right?
Yeah. Well, I mean, it's here, right? And it's here to stay.
Yeah.
So, when you look at a lot of some of the bigger, EMR companies, like Epic's a really big one. Epic already has essentially a device. You go in the room and you click a button and it listens to the entire interaction and it writes your note based off that. You can call out, physical exam stuff and it'll document that in your physical exam. You can call out orders. It'll make the orders. And so essentially you come out of the room and your chart's essentially done.
For sure. There are kinks, right? But the ironing out seems to be happening at an exponential rate.
Correct.
You pile all that information together, you put the corrections in. I mean, and then the difference is if it just means, hey, you have to read the report and make sure that something, is, oh, okay, well, let's just fix this detail. That's still, if you're 85% of the way there, that's still going to free up a whole lot of your time. Are you ready for this?
Yeah.
Yeah. I'm ready for it.
I'd welcome it.
Right.
I mean, if it gives me more time with patients, 100%.
Well, and again, I've made this point in previous conversations, but when have we ever been successful at holding back the future?
Never.
Yeah.
Especially when it comes to technology.
It's not going to happen.
Yeah. And you'll see it. I mean, you'll see it everywhere, but in medicine, you're going to see it everywhere. You'll see it in radiology, reading images and scans and, being able to have a conversation with a patient. At some point in time, they're going to it's going to give you a list, a differential or a list of potential diagnoses that you should be considering in this patient.
Yeah. Count me in.
Yeah.
I'm ready.
Yep.
We talked about emergency medicine can be crazy, can be dangerous. Recently, I got to speak with your colleague, Dr. Adam Dawson, and we talked a little bit about some of the personal side of this. I think I have your blessing to ask you.
Sure.
You see some difficult cases. You see people come in and they're all beat up and, they've been through a lot. If I may ask, what is that like for you? How do you navigate those situations? Not so much in a professional level, but on a personal level.
So we definitely all have cases that affect us for different reasons. And I think a lot of us kind of rely on each other, to maybe you had a case that didn't go great and you feel a personal responsibility for that, that can be really tough to go home and to turn that off and to be present with your family. So, our group of physicians here, as well as the residents and nurses and all staff, we try to have pretty open communication. One of the things we've tried implementing a lot more as far as, if a trauma comes in and like a serious trauma or a medical code, is taking some time afterwards for everyone that was involved, even if it's 3 minutes, to be able to just go into an empty room and to talk about the case and to just kind of be there for each other. I know I've had a couple difficult cases here and always able to rely on the other docs to be able to talk a case through and to get their true input on it. A lot of times I think it's just talking through the case, saying it out loud and your thought process, why you're doing what you were doing, and to get some honest feedback from someone can be really beneficial. But yeah, it's majority of the time we're able to, I think, separate kind of work from personal life, but there are those cases that it's just impossible. And that's kind of the nature of the job and what we signed up for.
Yeah. And the residents, and especially the young med students who are maybe in just for a rotation, they may be getting their first real dose of that.
Yeah, I think sometimes it's when we have a medical student on, watching someone get chest compressions and in the movies, it always looks, they get their chest pushed on and they're alive again. And in real life, it's a very brutal process, and it's not something that most people want to watch, even if they're planning on going into medicine. I remember the first time I saw CPR and someone coding and someone die. It's tough. It's very surreal, because you see that's a person there with a family and a life and people that care about them and maybe depend on them. So for me, I always, if I can tell someone is, seems like they were negatively affected by it, or if they're all of a sudden very quiet, I think it's, giving them the opportunity to talk or to, go outside and go on a walk and, just kind of get out of here for a little bit, clear your head. But always offering that safe space to be able to talk about it.
Well, that's serious, heavy material, and I hope that I haven't put a damper on your whole night for having asked you that. In the moment that we have left, I want to ask you about longevity in the medical context, because we know, as you said earlier, doing emergency medicine can lead to burnout, and yet you've also found that maybe for the people who are really wired for it, they stick around.
Yeah, particularly here. And kind of getting back to, you asked me earlier about, why did I want to stay here?
Yeah.
And for one, I have some great mentors. And I remember specifically Stevie Merrill and Jeff Conley, who are 2 ER docs here and also on faculty at the residency program, were telling me about, they actually came out here from Albany, and they're big mountain people, a lot of biking, backcountry skiing. Those are things we enjoy doing together. And I remember them telling me this was kind of like a 2-year plan, right? And I think right now, we're going on year 9 for them.
There you go.
So, and that's really like a lot of the other ER docs here. There's really good longevity. The core group of docs that make up our group that staff the ER are really strong. And, I think there's a lot of loyalty to this ER. And so that was really important to me, being a part of a group like that.
That's Dr. Clarke Snodgrass. He is an ER doc here at KRMC. Dr. Snodgrass, thank you so much for your time tonight.
Yeah, thanks so much for having me.
And that is the program. That's another edition of Focus on Your Health. I'm TG LaFredo, and thank you for listening. Stay healthy, and we'll catch you next time.
Are you on the radio again?